Like,
Sorry.
please start
Record.
I have started.
Yeah, good. Start.
Yeah. Good evening, everyone. Welcome to the Rural Service Bootcamp. And this is the 5th webinar in the series. And today's topic will be on the basics in ECG. So I'm sure that today's topic will be one of the most important topics in the series because ECG is a very commonly used tool. It is not expensive and it can be a life-saving tool. And sometimes due to the implications of reading an ECG, newcomers can find this topic a bit daunting. But fortunately, today we have two excellent speakers to help us out with the basics in ECG. And we have Dr. Alex Pattamanatom from the batch of 2014, who's currently working as a junior clinical fellow in the Cambridge University Hospital, UK. And we also have a very familiar face with us today and a brilliant teacher, Dr. Chaitanya Balakrishnan. He's a senior resident in the Department of Clinical Hematology and Bone Marrow Transplant in St. John's. So just a few reminders before we start the session. You can note down your queries and doubts. We can keep them towards the end of the session. And another reminder to fill the feedback form. I have pasted a copy of the link of the feedback form in the chat box. So please do fill the feedback form. And I think that should be it. Over to you, Alex.
Yeah, thank you, Chetan. Thank you for that introduction. And thanks a lot, Chaitanya sir, for agreeing to come for this class and then helping us sort this out. You've always been an inspiration to all of us, and you are an excellent teacher. So thanks a lot to Chaitanya sir again. And yeah, I'll start off. I'll share my presentation now. Okay. Yep. Okay. So basics of ECG. So we'll be basically covering very fundamental stuff, some technical stuff about ECG, how it's, what are the leads and stuff like that, how you attach, where you attach, and like very calibration and very simple basics first. And then we will see how you determine the axis of an ECG, how you calculate rate, and then we will go into arrhythmias. And we have I've classified it as 3. I'll deal with the arrhythmias that originate in the atria. So atria, and then junctional, and then ventricular. So this will be the order of the class. Then we'll just go forward from there. When I started my bond, it was quite a daunting task to handle an ECG. Like I was very afraid with an ECG. When someone gives me something, when someone gives me an ECG paper strip, I will be like, there are so many leads in it. So many are there. I don't remember any of those. What I remember last is the lead 2 that I studied in first year, sometime in physiology. And after that, I have no idea what happened. I am here. And then there are some stuff that I studied in final year just before exam. And then some ECGs I mugged up for my YUA and stuff like that. But yeah, I'm not an expert. That was my thought. So let's revise what we know in lead 2. So I'm sure you all remember this. So just take a look at this slide. You know the conduction pathway, you know the SA node, you know the AV node. Then there is bundle of S, then there is right bundle and left bundle. And there's a picture how a lead 2 ECG would look like. And that is lead 2 ECG. When we say lead 2 ECG, it's a very characteristic description of a ECG wave. And that helps us to name different deflections in the ECG. And we know what these deflections are and what are the actual events, what are the electrical events actually happening in the heart. So let's have a look at that. And you know what is a P wave? P wave is the electrical event that's happening, and that is causing the atria to contract. So atrial depolarization, that is what's happening with the P wave. Then you know there's a Q wave, and there's R wave, and then S. So QRS complex, that's the ventricular depolarization altogether, and each wave has a definition. So when you say what a Q wave is, that is the first negative deflection after P, and then R is the first positive deflection after P, and then S is any negative deflection after an R wave. So that is the basic definition about these waves. So sometimes you may or may not see a Q wave in almost all. You may or may not see a Q wave in an ECG. So that doesn't mean that, and that means it's not a necessary criteria that all the waves, or everything should have a Q, everything should have an R, everything should have an S. There could be different ways QRS complex can present. And yeah, so we know the lead to ECG, and then the thought process in my head was, then I know this, and this will tell me what the heart is doing. This will tell me how fast it is beating. Then what is the need for all these other leads? What is the need for the 2, 3, AVF, AVL, V1 to V6? What are all those? So the basic understanding that you all should have is, so we have the heart there, and these leads are different cameras placed at different angles all around heart. So 1, 2, 3 AVL, 1, 2, 3 AVL, AVR, and AVF in a coronal plane, and the rest in a cross-sectional plane around the heart. So that is where these things are placed, and that is how, and these leads look at the electrical events from all those different angles. Okay, yeah, so that is why we have all these leads. So after that, squares, numbers, and speed. So each ECG paper, when you take an ECG, it is set, the paper is set to go through the machine at a specific speed, 25 millimeter per second. You can change that speed in your ECG machine, but as a standard, we have set it as 25 millimeter per second for interpretation and for uniformity. That is the most commonly used speed. And from that setting, we have the paper, we have the boxes and the distance and stuff here in the paper. From this, we can calculate and come to many conclusions. So that will essentially tell us what is time in that paper. So how do you say that? So one large square, so this is a large square. If you can see my mouse pointer, this is a large square in an ECG. So one large square, that is equivalent to a 0.2 second. Okay, and when one large square is equivalent to 0.2 seconds, 5 large squares will make 1 second in an ECG. So if you count from here, 1, 2, 3, 4, 5, 5 large squares together makes 1 second in an ECG. So that's the electrical event happening in that 1 second. So if you, this is a very important understanding that you should have. That's one. And every small square in the ECG is 0.04 second. And you know the time by now you understood that the time is measured in the horizontal axis. Okay, every small square, the small square here, that's 0.04 second. It's important you know these values because it will help you to calculate different intervals in ECG, and these intervals are needed for you to come to different conclusions. You must also remember the Einthoven's triangle and Einthoven's law, and it's based on this that Einthoven has developed the entire concept of ECG. And basically, this whole diagram there, it says lead 2, the vector sum in lead 2 is equivalent to the vector sum of lead 1 and 3. So yeah, that's how you get it. So lead 1 is essentially, it's going like this towards the right. So that's the vector. And this is lead 2 vector going from the heart towards the left like this. And then there's the lead 3 vector going like that. So just have a look at that. It will come handy in next few slides. So we finished. Then what is a good ECG recording? Many of you will have a lot of trouble in getting a good ECG recording. You might get haphazard ECGs handed over to you by nurses in your burn center, and you will be looking at that and you'll be thinking, what is going on in this patient? Is it a good recording, or is it actually something wrong happening with the patient? So if you don't get a good recording, interpretation will be very difficult. So most important thing is you need to have a correct calibration. and the paper speed. So you need to ensure that the paper speed is 25 millimeter per second, and the calibration is correct. I'll speak about calibration in the next slides. And then make sure all 12 leads are clearly visible with a good definite baseline. Okay, and any movements, if the patient is shivering, if the patient is cold, and if he's moving around, and such things can cause very poor lead contact, and that can cause a lot of electrical disturbances in the ECG recording. Another common cause, some other common causes are sweaty skin, hair, creams applied on skin, things like this can cause a lot of disturbance in an ECG recording. How you can tackle that is basically rub that area with an alcohol wipe or a nice towel so that it becomes very dry. And yeah, so how do you see when I say disturbance, what does that show in an ECG paper? So you might see very thick, irregular baseline. That is basically because of electrical disturbances. Look for any motors or any metallic objects that's coming in contact with the patient. Yeah, so such things also can cause electrical disturbances. Make sure the leads are placed correctly. Many times you get limb lead reversals and things like that. When I say that the leads won't be attached properly, the left limb would be attached with the right limb lead or things like that. So when such things happen, you will have a completely abnormal recording. So yeah, how you ensure that there is correct lead placement is basically by looking at these features, that P and QRS are upright in lead 1, and those are negative in AVR. So in AVR, all these waves will be negative. So make sure that it's negative in AVR. Take a look at the AVR when you get handed over an ECG first, and then make sure it's all negative. Then yeah, your the lead placement will be correct. And yeah, good R wave progression. So yeah, you need to ensure that there's a good R wave progression, and that indicates there's a correct chest lead placement also. But yeah, poor R wave progression can also happen in abnormal cases. We'll speak about that later on. Okay, then comes how to report an ECG. It's easy to say an ECG is normal, or just to say, okay, there's an MI or there's an arrhythmia or something like that in an ECG. But just by saying one word won't do complete justice to an ECG. So how you report an ECG, it's important to have a systematic approach to it. So yeah, here's an example for that. So you go by rhythm, rate, conduction intervals, look at the cardiac axis, you describe the QRS complex, describe the ST segment and T wave, go in that order. And if you remember this checklist, then you won't miss anything. You can just go through each of these things and interpret your findings, and then finally formulate something like that. I've put an example there. You can have a look at that. And then something like that would be a very good final interpretation of this ECG, of whatever ECG you're handed to. When I say checklist, I have a checklist here. So this is a 2-page checklist that I have. So this is the first page. So these are the things that you should go in a sequential order when you look at an ECG. And when you go through that, you won't miss anything. You'll ensure that you have covered almost everything. So you need to look at the standardization. You need to look at the technical features that I've told. P and QRS complex are upright in lead 1 and negative in AVR. And rhythm, heart rate, PR interval, QRS interval, axis, P waves, and then QRS voltage, precordial R wave progression, abnormal Q waves, ST segment, T, U, and then finally, you need to compare it with previous ECG. So I'll share this document of standardization, this checklist with you all in the group. So you can keep it with you when you start interpreting initial set of ECGs that you get, and make it a habit. You go through this checklist, and then you will not miss out anything. And our class, we will be following this order when we go forward. Okay. And next up. Yeah. So the 12 leads. So remember what I said. These 12 leads are basically cameras placed at different angles. So if you look here, this is lead 1, and that's a camera sitting there looking at the heart, and interpreting the electrical event that's happening here. So we have the SA node here, we have the AV node here, and then we have the bundles and stuff like that. So electrical activity is conducting down from the right atria towards the ventricle in this fashion almost every time. And each leads are sitting at different angles. So lead 1 is sitting here, lead 3 is sitting here, AVL is sitting here, AVR is sitting here, and all these leads are looking at the same electrical event in the same time and making a recording. So any electrical current moving towards the lead would essentially cause a positive deflection. And any electrical current moving away from the lead, so any electrical event moving away from the lead would cause a negative deflection. A classic example in this is if you take a look at lead 2, so you know that atrial depolarization, that the P wave starts from the SA node, conducts through the atria, and then come into the ventricles. And the P, that current is coming in this direction. You can see the P is positive. And then when that current enters the ventricle, you have the QRS complex. When the ventricles are depolarizing, you can see that the current is traveling in this side, in this direction, and lead 2 is picking up a positive deflection there. That's how it is. And if you look at AVR, at the same time, the P wave, it was moving away from AVR. When AVR is sitting here and looking at the electrical event happening in the heart, you can see the current is moving away from AVR, hence a negative deflection, and the P wave is a negative P wave. And then when the ventricles are depolarizing, the current is moving away in this direction, and AVR is having a negative QRS complex. So that is what I spoke about, the entire camera event. So these things are sitting at these angles in around the heart, and then they are recording the electrical event. And then you have the chest leads. So V1 to V6, these are placed in a coronal plane around your heart in a specific position. So here I have made the list of the exact anatomical landmarks where you place these chest leads V1 to V6. And that is exactly where these leads should sit. And when you place them correctly, it should come up to something like this. So yeah, you have the red lead, that is the right limb lead, right upper limb lead on your right upper limb, and then yellow, or it's a left upper limb lead on your left wrist. And then you have the left lower limb, that's a green lead on your left lower limb, and then the black one, that's a neutral, so that will go into your right lower limb. So that is the limb lead placement. And then here you have the chest lead placement. So what you need to do is find out the angle of Louis, which I know you guys remember from first year. And then just below that, you can find the second intercostal space, count again one down, third intercostal space, one more down, fourth intercostal space, just about at the level of nipple. So either side of sternum, you place one lead each, V1, V2. Then you go forward and place V4. You don't place V3. So after V2, you place V3 because, so after V2, you place V4 because V3 doesn't have a proper anatomical landmark. V4 is to be placed in the mid-clavicular line. So this is the clavicle, this is the clavicle, mid-clavicular line. So you make an imaginary line there, just just in fifth intercostal space, you keep the V4, and then in the same intercostal space, same plane, you keep V5 and then V6, but V5 on the anterior axillary line and V6 on the mid-axillary line. And then you place the V3 in midway between V2 and V3. So just to recap again, fifth intercostal space, V5 and V6, and then V3 midway between V2 and V4, V4 in the fifth intercostal space, mid-clavicular line. I hope you guys got that. All right, okay, so yeah, so that's how you place it. Then you have a very good chest lead placement, and then you take the ECG, and yeah, now the next part that we are going to deal is how do you interpret a cardiac axis? I will come to interpreting rate later. I thought since I've been talking about cameras, angles, and lead placement, I thought it's nice to continue with cardiac axis at this point and finish it off. Yeah, so we will continue with cardiac axis. So cardiac axis is basically the sum of depolarization vectors generated by individual cardiac myocytes. So it's all an electrical event, isn't it? So where is this electricity in net going? In what direction is it traveling? And what direction is it traveling? The direction will be basically decided by the net electrical events in each muscle fiber. So if there is an infarct, or if the muscle size is big on one side, or something like that, would essentially influence the cardiac axis. If there's a lot of muscle mass on the left side, definitely the axis is going to be more shifted to the left side, because there is more electrical event happening on the left side because of the muscle mass. And then the net electrical vectors would be shifted to the left side. So things like that. Yeah, okay. So how do you interpret the cardiac axis? There are many methods that were described in this. I'll introduce you to all 4 methods, but my favorite is the Super Sam Axis Man. That's how it is called in a very good website called Life in the Fast Lane. Yeah, so I'll just go through all these methods and then describe it to you. Before we go into detail, just have a look at this diagram here. So you remember Einthoven's triangle, and from there, by repositioning the vectors, so yeah, lead 1, it's like this. It was in this direction between the right upper limb and left upper limb. In the Einthoven's triangle, if you remember right, lead 1 was in this direction. So just moved it here. So this is lead 1, and then lead 2, it was between the right upper limb and left lower limb. So this is lead 2 being placed here. You just moved, rearranged the vectors, but without changing its value or anything. You just moved it here. So it sits there at 60 degrees. And then lead 3, which was between the left upper limb and left lower limb, just moved it here across. So that's sitting at 120 degrees. So these are the axes or degrees at which these leads sit, and then look at the events in the heart. So just remember these degrees, they are all placed at certain degrees, and it is at those angles these events record the electrical event. So basically, when you go into the quadrant method, what you need to do is you need to plot out the QRS complex height, the height of the QRS complex in each of these leads. So you just, for example, yeah, okay. So you need to see in a quadrant method, so you just use 2 leads, lead 1 and AVF. And so lead 1 is in this direction, and AVF is at 90 degrees, right perpendicular to lead 1. And then all you do is look at the QRS complex and see if it's positive or negative. The QRS complex is positive in net, so then you will label it as positive. So, and then if the AVF is positive, you again label it as positive, and that will make it here. The lead will, the axis will be somewhere here. So this is lead 1. Anything positive will get recorded here, and this is AVF. Anything positive will get recorded in the positive limb, and this is where it's going to be. And then again, the same thing. What you do is again you look at lead 1 and then positive, negative, and you plot it accordingly, and then you will get different axes at different with different net QRS deflections. So that is how you do a quadrant method. And then there is a 3-axis method. Here, all you do is you just add on an extra lead into the first 2 leads that you used. So you use lead 1 and AVF, one at 0 degrees and one at 90 degrees. And then for getting more accuracy, you add an extra lead into this, and then interpret. So when you add in an extra lead, ideally it should be one that placed 90 degrees apart to each other, and then and then you plot it out, and then you will get a better idea of where the electric current is going, and you will be able to interpret the axis correctly. Then there is something called isoelectric lead method. So here the most important thing is to find out what the isoelectric lead is. So in an isoelectric lead, the net deflection of the QRS complex will be 0. And when I say net deflection is going to be 0, you would have seen ECGs where there is some part of QRS complex going up, and then there's some part of QRS complex going down. When you add these both, if it's coming as when you add these both, if it's coming as 0, that is when you say the net deflection of the ECGs is 0, and that will be your isoelectric lead. And what does that mean when you say the net deflection is 0? It means that the electricity, the net electric current, is completely perpendicular to that lead. So if you have a lead like this, and then the electricity is completely perpendicular to it, this lead won't basically pick up anything. It will just see things. There's an electric current coming to it, and then there's an electric current going away from it. So it will just balance itself out. So that is an isoelectric lead. And so where is the current going? So the current is going at a direction 90 at very perpendicular at 90 degrees to this, and that would be your direction. That would be your axis. So you find out you find out the isoelectric lead, and from the graph that you know, from this graph you find out what is the lead that is sitting at 90 degrees to this lead, and then you know the axis. So in that lead, the current, the QRS deflection will be positive, indicating that the current is going in that direction. So I've described all those three methods quite fast, basically because those are not that accurate, or those won't be that well used by most of you all. Best thing to always do is to just plot the net QRS complex deflection or measurement just into this graph or the lead. So just to give you an example, if you get an ECG where in lead 1 there is, say, 5 positive deflections of the QRS complex, and then almost no negative deflection of the QRS complex. So you just plot like 1, 2, 3, 4, 5, somewhere around a bit 5 centimeters, somewhere around here, and then look at AVF, and you look at the net QRS complex deflection in AVF. If it's positive, you just plot it out a bit down here, and then look at lead 2, you plot it out there, and then you will kind of, then if you find the intersection point of all these three plotted out values, then you will basically get where the axis is sitting. So so most important thing in axis determination, just to keep it very simple, is to remember this diagram where these leads are sitting, and then look at each of these leads and see what is happening in each lead. If is the net QRS complex deflection positive or negative, and then you will be able to figure out what the axis of the ECG is. Okay. All right. So once you figured out the axis, so you will get to know whether there's a left axis deviation or there's a right axis deviation. And there are lists of causes for left axis deviation and right axis deviation, but none of these things are just confirmatory. Like just by saying, okay, there's a left axis deviation, you can't completely you can't make any of these diagnoses, but these things should be there at the back of your head when you see an ECG with a left axis deviation or a right axis deviation, so that it will aid in your diagnosis. It won't make a diagnosis, it will just aid in your diagnosis. That's all. Okay, so believe you guys got access determination. If you guys have any doubts, you can just ask. If I was not clear anywhere, you guys can unmute yourself and you guys can ask. If not, if you guys want me to just continue, then we will continue. Can you let me know? Hi, am I audible?
Yes, Alex, you're audible.
Yeah, I think, are you guys able to see my pointer when I was pointing stuff, or is there any trouble in that? Okay, can you see a pointer now?
Yeah, I can see your point.
What was there a pointer? Could you see my mouse pointer earlier on?
Yeah.
Okay,
It's
all
visible.
right. Yeah, okay, yeah. So I think we'll just continue from here and then take all the doubts at the end. Okay, so next is calculation of rate. How do you calculate rate? So most important thing is you would have studied this formula in first year, and that has stuck in our heads, and that's how we usually calculate rate in our common practice. But the first thing is not to just directly blindly apply the formula, but to check at the RR interval. So you need to see if the RR interval is constant or not. If the RR interval is constant, then yeah, you can use this formula. And then that's just 1500 by number of small boxes in one RR interval, and or 300 divided by number of big boxes in one RR interval. If you guys want to think, you guys can go back and then just work it out in your head from the fact that our paper speed is 25 millimeter per second. And then you guys can work it out how this formula has come. It's nice. It's interesting if you guys love maths. Otherwise, just forget it. It's simple, but it's nice. If you guys want to, you can work it out. Otherwise, for all practical purposes, you can just, if you can mug up this formula in your head and then just use it directly, it should give you a reasonable calculation of rate. And then the trouble comes when the RR is not constant. When you have an arrhythmia, when you have a patient with an arrhythmia, when the RR interval is not constant, that's when the trouble is coming. So what you need to basically do is, what is heart rate? How heart rate is number of beats per minute. So that's the basic funda of it. And each beat, each ventricular contraction, or each ventricular depolarization is shown by a QRS complex. So you need to basically count it out from your ECG. So what you need to do is you need to plot 6 seconds or 10 seconds in the ECG. If you guys remember in the beginning, I mentioned each big square is 1 second. So yeah, and then from there you just, sorry, each big square is, did I make a mistake there? Yeah, so each big square is 0.2 seconds, and then 5 large squares make 1 second. So all you have to do is you just need to remember that 5 large square is 1 second, and then count it out. So when you count it out, take 5 large squares, 1 second, make a mark there, another 5 large squares, another second, make another mark there. So count out, plot 6 seconds or 10 seconds just for easy for convenience and calculation. So just plot it out and then multiply it to make 60 seconds, and then you will basically get the rate. So you plot out 10 seconds and then count how many QRS complexes are there. Just multiply it with 6, and then you will get how many QRS complex would be there in 60 seconds, and that will basically give you the rate. Okay, so that's you just need to count it out when you calculate heart rate in a patient where the RR interval is not constant. Okay, so next we go into arrhythmias. We are going to appreciate the rhythm. How do you find out what rhythm the patient is in? What is the electrical rhythm that the heart is in? So most well appreciated, the best two leads to look at the rhythm or to interpret the rhythm is lead 2 and V1. Why I say that is P waves are best visible in these two leads. So if you have any doubt if the P waves are actually visible in an ECG, if that's a P wave or something else, something like that, it's best to look at lead.
Oh, I thought it was the problem with my computer. I think Alex is frozen. I just tried to. Think he's left. He'll come back.
Meanwhile, if you have any doubts, you can ask Dr. Chaitanya as we reconnect with Alex.
Alex will be back. Give him a couple of minutes, 2 minutes. I asked him to leave and join. Screen was stuck.
Anybody has any queries can put a hand up in the chat and I'm happy to hear. The Alex back.
Could you only? Yeah, I think something happened with my laptop. It's not responding. I know what happened. It's just I'm finding it difficult to rejoin into the call.
I think it was also Teams issue, Alex. It happened to me yesterday from our department laptop. Just froze. I had to reinstall Teams.
Yeah, Teams is not responding at all. I don't know.
Same thing happened yesterday as well. The screen just freezes.
think, yeah, everything freeze. Yeah, true. Think I'll be able to rejoin now. Let me see.
Yes, Alex, we can see you now.
Oh, but yeah, can you see me in my laptop or you see me in the phone? I'll just cut the
I think it's your phone.
I think it's the phone. Okay, let me see if it's letting me join. I'll send my PPT across, but I don't know, like everything is frozen in my.
Will I take the vision ECG that I had for access and calibration till Alex?
Yeah, yes, sir. You can continue.
But then I'll just share my screen.
Sure, sir. Yeah, it's visible.
I'm just going to Alex get technical part up. Just plan was to revise all the ECGs at the end, but I'll just revise the couple of ECGs that Alex has taken so far. As he stressed upon, when you look at an ECG, and this is something that he mentioned and I always teach, is that never start reporting an ECG unless you look at this block on the left, where my pointer is at. So that is an inscript which shows you whether the ECG has been calibrated correctly or not. So this particular annotation should always be 2 boxes in height and 1 box in width, that is big boxes. And if you look at the two contrasting ECGs that I've put side by side, this one is wider. It's abnormal because it's 2 boxes width. It should normally be 1 box in width. While here you look at it and this is less than 1 box in width. So you have two contrasting calibrations showing. And you see the difference in how the complexes look. The moment you widen the calibration, the complexes are much more stretched out. The moment you narrow it, of course, the complexes look close. This is useful to widen it when you're dealing with an arrhythmia, and Alex will come to that eventually, is that when you're dealing with certain types of arrhythmias, when the heart rate is so high, it's sometimes difficult to interpret what's going on unless you stretch out the ECG. So often people tend to do a stretched out ECG just to look at the waves of, especially the morphology of the QRS, to look for a hidden P wave and to look for the morphology of the T wave. Whereas if you look at the narrow complex, I mean, if you look at when the calibration is narrower, your complexes are much more bunched together. It's very difficult to make an exact interpretation. If you look at the second ECG I've put up is even if the height of the calibration is normal. So the normal calibration signal is about 1 centimeter is 1 millivolt. That is, or 1 mm is 0.1 millivolt. So the normal height calibration should be 10 small boxes or 2 big boxes in height. If you look at the one on the right side of the ECG, it's the same patient's ECG. The moment you shrink or the calibration is shorter than normal, the change in the QRS complex is dramatic. The implications of this is your calculation for chamber hypertrophy, your calculations for left ventricular, right ventricular hypertrophy, your calibration for R wave progression and quantification of the RS ratio will thereby alter. And you may report low voltage complexes when actually the complexes are normal, or you will miss a chamber hypertrophy and report it as normal if your calibration is abnormal. So it's extremely important to look at ECG calibration before you start it. The second thing that Alex beautifully mentioned is again standardization and calibration. Again, as he said, 25 millimeters is 1 second. That's the speed of the paper. And if you're mathematically inclined, you will look at the finer calculations. But if you're just looking eyeballing an ECG, one large square is equal to 5 small squares in height and width. One small square is 0.04 seconds on the axis, horizontal axis, thereby equal to 0.2 is 1 big times. Why are these calculations important? When you're defining certain AV conduction blocks, when you're defining whether it's a broad complex or a narrow complex tachycardia, the the value or the number of boxes occupied by the complex of the segment is critical. So you need to ensure that your calibration and standardization is. Alex also mentioned about, there he is, he's back.
Alex, I think you're muted.
Yeah. Can you hear me? Am I audible?
Yeah, you're audible. Yeah.
Yeah.
Yep.
Hey, sorry for that glitch. So till where did we see? Okay, axis deviation. Yeah, I think I just finished with axis deviation and then I'll, present. Okay, can you hear me?
Yes, you're audible, Alex.
Yeah, all right, all good. Yeah, so we finished with axis deviation. We finished with calculation of rate, and we finished with the basics of very good recording. We finished with squares, numbers, and speed. And this is basically your calibration, the squares, numbers, and speed. So to ensure that the ECG is calibrated well, you need to make sure that it's set at 25 millimeter per second paper speed, and then the voltage setting should be 1 millivolt, should be equivalent to 1 centimeter. That's about 2 large squares, and that is the standard calibration. So if you look at an ECG in the beginning, you will see this bit, a small a vertical box like this. Okay, so this horizontal axis is the time, and that is set like that. And here, this is a voltage deflection that's set. So 10, 1 millivolt equal to 1 centimeter, 10 small boxes. Yeah. So we finished all basic stuff, and now we are going into rhythms and different rhythm abnormalities. Just as I said in the beginning, we will be dealing with all the atrial rhythms, we'll be dealing with junctional rhythms, and then we'll be dealing with ventricular rhythms. We'll just touch upon the basic management principles of all these rhythms and what you can possibly do in your bond center. Okay, and I told you what leads that you need to look closely to identify the rhythm and where you can see the P wave well. And I told you the importance of a rhythm strip and what is a rhythm strip. And yeah, that is where we are. Then the next part is the first abnormal rhythm. It's not abnormal. It's first arrhythmia that I would like everyone to know about is sinus arrhythmia, which is normal and which is very common, which is just with respiration, and it's very commonly seen in young people, and it would look something like this. If you look at it, you can see there are definite P waves in front of all QRS complexes, and the P and QRS complex relationship seems to be consistent and seems to be normal. That is when I say about the relationship, that's the PR interval, and the PR interval is normal and constant. A normal PR interval is 120 milliseconds to 200 milliseconds, and this is again another value that you need to remember, or if you just use the checklist, you have the number with you. So yeah, the PR interval is constant. And so, you know, when such a thing is there, when the P wave is there, PR interval is constant, all P waves are immediately followed by a QRS complex, a narrow QRS complex, you can say the patient is in sinus rhythm. So the SA node is the boss, the SA node is creating the P wave, and yeah, so SA node is the boss. Whenever SA node is the boss, you can say, yeah, this is in sinus rhythm. Okay, and then you see, look at the RR intervals. There is some difference. So here the RR interval seems to be quite big. It's short. It's short. Again, it's becoming a bit more bigger. So there is a difference in the RR interval. So there is a progressive beat to beat change in RR interval, and that is called sinus, because SA node is still the boss, sinus arrhythmia. And this is common. You don't have to do anything when you see that. Okay. Next, we go into abnormal rhythms. So in the abnormal rhythms, we will be talking about, just like I told, supraventricular, ventricular rhythms. And in supraventricular rhythm, it could be sinus arrhythmia, just like I told, and then it could be atrial or junctional rhythms. And in all these cases, in all these supraventricular cases, the rhythm, the QRS complex will be a narrow QRS complex, provided there is no bundle branch block or Wolff-Parkinson-White syndrome or anything like that. So if the electrical activity is originating somewhere above the junction, the junctional zone, somewhere above AV node, but essentially getting conducted into the AV node and then going into the ventricles through the normal proper channel, that is through the bundle of hairs, and then the right and left bundle branch, and following the normal conduction tissue to spread the electrical activity, then you will always see a narrow QRS complex. If this depolarization of the ventricles is happening through any abnormal pathway, that is something different from this, it would always be a broad QRS complex or an abnormal QRS complex. That is mainly because when the depolarization is not happening through the proper specialized conduction tissues, when it's not happening through that, but instead is happening through the myocytes, then the conduction speed, the depolarization spreading would be very slow, and hence you will see these QRS complexes becoming big. That's all it is. Okay, so yeah, we will be dealing with all these things. Yeah. So in supraventricular rhythms, you may see a P wave. P wave may be present, P wave may be absent. You may not be able to identify it. You may see it merged inside a QRS. You may see it right outside a QRS. You might see something called a pseudo R wave. So these P can take different forms in a supraventricular rhythm. And you will, in the coming slides, you will basically see these different avatars of P, and that will tell you what exact supraventricular rhythm is the patient is in. Okay, so we'll go forward, and as we go forward, this will become more clear. Okay, so next atrial rhythm that I would like to discuss here is an atrial escape. It's not a rhythm. You'll basically see an abnormal atrial escape beat, something like that. Okay, so if the SA node fails, and then if the SA node does not fail, if the SA node is not able to keep generating the impulses and if the SA node is not being the boss anymore, then someone else has to take up that role. And then some random focus in the atrial musculature or in the AV node or the junctional region, something will take up that role, and whenever the focus is from the atrial muscle, it will start generating impulses at around a rate of 50, and then these rhythms will happen. So atrial escape, in an atrial escape, it will be something like this. So this is not exactly a P wave. It's something a bit abnormal. So that And that tells you, okay, this has generated somewhere from the atria, but not from SA node. So if it's from SA node, you will definitely see a proper normal shaped P wave. So, and then after that, that impulse has gone into AV node, and from there it has just followed the normal conduction pathway. So that this normal shaped QRS complex will tell you that the impulse has gone into the ventricle through the normal channels, and then you have the rest of the electrical events happening just normally. So something like that, when you see something like that, just one off, you can say, okay, that's an atrial escape beat. And then right after something like that, you will see a compensatory pause, and then a sinus arrhythmia, and then just return into normal beats, normal P, QRS, and Ts. Okay, so that's an atrial escape that you see here. Next one. So next is premature atrial complexes. This is also called quite commonly as atrial ectopics, atrial extrasystoles, atrial premature beats, and atrial premature depolarizations. So here again, there's an abnormal P wave, usually just like I told, like followed by normal QRS complexes, and you can see post-systolic poses. And yeah, the main key in this is the P wave morphology is different. It's not normal. So yeah, so it's not the SA node who is dictating these rhythms anymore. It's a focus that's from somewhere else dictating these rhythms. Okay, so yeah. So what is the clinical significance of these things? So this would be because of atrial enlargement, ischemic heart disease, or something like that. And yeah, so the problem with this is when you see too many premature atrial complexes in an ECG, you need to worry whether the patient can go into atrial fibrillation, flutter, or some other supraventricular rhythms that can cause an arrhythmia for the patient. So that is what you need to worry when you see this. Common causes are like the abnormal electrolytes. So check the electrolytes and make sure all those are in normal range, and then review the drug list of the patient, and that might help you to find out what is the cause for all these. Okay, so yeah, what you should do in your bond center, just as I told, check your electrolytes and think if the patient has any structural heart disease that would actually cause this. And most of the time, it's it's some electrolyte abnormalities corrected. If not, it's benign, so you don't have to do anything. Reassure, counsel the patient, and if the patient is becoming symptomatic or anything like that, you might need to discuss it with your cardiology, and then might have to do an echo or need to consider an ambulatory monitoring. That's something like a 24-hour Holter or something like that. Okay. So another risk about these things, if the patient develops an AF or some abnormal rhythms of atria, you should always think about the patient having a clot being thrown into systemic circulation, and that could cause a stroke. So when we go forward, we will talk about the importance of using anticoagulation in all these patients, in patients particularly with AF and flutter and things like that. So next is supraventricular tachycardia. So supraventricular tachycardias are basically, again, tachydysarrhythmias that arise above bundle of His. And for ease, you can just classify all the SVTs into this. So it could be a regular one that is arising from the atria, a regular atrial, a regular atrioventricular involving the atria and the ventricle, and then the irregular atrial one. So regular atrial, you all know what sinus tachycardia is. So P wave followed by QRS complex. Patient is in sinus rhythm, regular, but there is an increase in heart rate. So sinus tachycardia. And we saw what is atrial tachycardia. we will see atrial tachycardias in the next few slides, and then atrial flutter, and yeah, then all other things we will see in the coming slides. And then we will see AVRT and AVNRT and junctional tachycardias. And we will also see atrial fibrillation, we will see atrial flutter, and then multifocal atrial tachycardia. So this is a classification just for you to understand. So atrial tachycardias. So different types of atrial tachycardia. There is focal atrial tachycardia, which is basically due to a single ectopic focus. And then there is multifocal atrial tachycardia, that's also called MAT. And then there is atrial flutter. So in a focal atrial tachycardia, you can see it's just one single ectopic focus that's sitting there in the atria and constantly firing, causing this abnormal P wave like structure just before the QRS complex. So it's not a proper P wave because it's not generated by SC node, it's generated by some other ectopic focus, but in the atria. So it's abnormal in shape, abnormal in deflection. So yeah, so it's something else. So you can see here that that's an inverted P wave, inverted P wave like wave. So yeah, and then immediately followed by QRS, and then that keeps on going, and it's a tachycardia. So that is a focal atrial tachycardia. You would see an ECG rhythm, something like this. Here also, since the event this since the arrhythmogenic event is happening above the junction, above the AV node, all the electrical events below the AV node is just conducted normal, and you can see a normal QRS complex, normal T, and things like that. So it's the problem is only here. Okay, so you will see an isoelectric baseline because it's just one focus it's triggering. That's an abnormal one. There's an isoelectric baseline, unlike atrial flutter. So yeah, that's how it is. So when you see atrial flutter, you will be able to make that difference. Okay. Yeah. So what would be the cause for this focal atrial tachycardia? The causes could be many things. Anything that can cause an atrial stretch, infarctions, pulmonary decompensation, infection, dyslipidemia, hypoxia, and stimulants like cocaine. So things like that can cause focal atrial tachycardia. How do you manage that? If the patient is unstable, you would need to consider DC cardioversion. And even before that, you can, if the patient is unstable, definitely it's a DC cardioversion. If the patient is stable, you can attempt some vagal maneuvers like carotid massage. So this will increase the vagal tone and then basically abolish these arrhythmogenic centers. Okay, and then it's important for you to identify what are the precipitating factors? Are there any drugs or any electrolyte abnormalities or anything like that? If the patient is stable, then pharmacological management options would be stuff like beta blockers and calcium channel blockers and amiodarone. But most of the time, I don't think you will come across any of these in a bone center. And if you need to prescribe any of those, like amiodarone or something, it's better if you could seek out senior help and then take it from there. Okay, next is another type of atrial tachycardia. So this is multifocal atrial tachycardia. So just as the name suggests, it's multifocal. So if you look at the ECG here, you can see earlier you saw one single abnormal P wave, which has been constant, same in shape, causing all the QRS complex with the same relationship between QRS complex, and it was just consistent throughout. So that was happening in a focal atrial tachycardia. Here in the multifocal atrial tachycardia, basically what happens is there are different focuses within the atria causing these triggers and then causing this, and then those focuses act on, they send the impulses down and then cause the tachycardia. So how do you identify that? You look at the baseline, see that there are different morphologies of P waves different varying relationship between the P wave and QRS, implying that it's not at the same anatomical location that these abnormal electrical impulses are generated in the atria, but at different locations. How can I say that? So if the impulse is generated very close to the AV node, you will see a very short PR interval, because that impulse, the P wave, the presumed P wave, will easily conduct to AV node very fast, and then you will see a short PR interval. So you will immediately see a QRS complex. If that, suppose that arrhythmogenic area or that focus is somewhere further away in the atria from the AV node, it will take more time for that impulse to conduct from that point till the AV node. Hence, there will be a longer PR interval. So there are varying PR intervals, varying morphology of the P wave. So you can see this is a multifocal atrial tachycardia. So you will still see an isoelectric baseline between the P waves. Unlike the flutter one, you will still keep seeing that. And yeah. So where do you see these things? You see these things in COPD, right heart failure, basically very sick patients in ICU. That is where you actually see these things, and then you need to manage the underlying condition, and that would help you definitely control this multifocal atrial tachycardia. Next important thing is atrial flutter. So this is basically caused by reentry circuits in right atrium. When you think about an atrial flutter, the most important thing that you look at the ECG here is the sawtooth appearance. So the atria is going on contracting at its own rate. So you see multiple atrial contractions seen as the sawtooth appearance. And then not all of those are conducted down, but some are conducted down, and whatever is conducted down is causing a QRS complex. So, and based on the number of atrial contractions before one QRS complex is getting conducted down, you can say there are varying AV conduction ratio. So you say there's the 2:1 block, 3:1 block, 4:1 block. Basically here you can see an example 1, 2, 3, 3:1. So every three atrial contractions. So every 3 atrial depolarization or every 3 P wave like structure, one is getting contracted down, and that is how an atrial flutter rhythm would look like. And the rate would be very high of the atrial activity, but the ventricular activity will depend on the conduction ratio. An atrial activity rate would be very high at around 300 beats per minute. So count the number of P wavelets thing, and that will give you the atrial activity, and it would be a regular atrial activity. That's what happens in a flutter. Just take a look at this ECG. This is the rhythm strip. If you see here, this is the calibration. Calibration is normal. And then if you look at the rhythm strip, you can identify the abnormalities very well. You can see the sawtooth appearance with varying conduction rates. So here 2:1, here it's 3:1. So 3 P wave like structures and then 1. Here again it's 2:1. So yeah, so varying conduction rates, and that is how atrial flutter would look like. How would you manage? So management of atrial flutter would basically be by beta blockers and digoxin. And this is not to control the atrial rate. This is basically to control the ventricular rate. You would be worried if your patient has a very high ventricular rate, mainly because the cardiac output will be compromised when the ventricular rate goes up, and that is a cause of worry for you. So in such a case, you would consider using digoxin or beta blockers to control the ventricular rate. A reversion into normal sinus rhythm would be the definite management. For that, you would need radiofrequency catheter ablation. That is something beyond you in your bone center. So you will have to refer this patient for further evaluation and then management. And so far, the studies have seen that the catheter ablation is the best thing, and that has a higher efficiency than all the pharmacological agents that we could use. Very important thing as a bonder that you should remember is to anticoagulate these patients. So you need to consider giving them some long-term anticoagulation because when the atria is not contracting properly, or in all these atrial events, when it's this could cause systemic embolization. Patient could end up with stroke and things like that. So you need to remember to anticoagulate these patients after doing a anticoagulation risk scoring. We will come to the risk scoring when we speak about atrial fibrillation. Next is atrial fibrillation. If you look at the ECG here, you can see that there are so many abnormal, irregular structures in between the QRS complexes. So those are fibrillatory waves. So the atria is not exactly contracting. It's not a proper P wave, or it's not a proper it's not a proper impulse, but it's just fibrillating. There are multiple wavelets causing this. So you can see the fibrillatory waves, and then you can see the normal QRS complexes, but very irregular. So important ECG features that you need to look at is regular rhythm. You can't see a P wave. These are fibrillatory waves. You can't call them as a P wave. So absent P wave, you might even see an ECG with irregular rhythm with almost flat lines. The fibrillatory waves can be very fine, so you won't even be able to make it out. So yeah, so absent P waves, absence of an isoelectric baseline. Because of the fibrillatory waves, there won't be any isoelectric baseline, varying ventricular rate, and then the rate would be somewhere around just less than 120. And yeah, so these are the features that you would look at, and you would look to look in an ECG. And when you see these features, you need to think of atrial fibrillation. How do you manage atrial fibrillation? So management of atrial fibrillation, there are two main concepts behind it. You can either rate control or rhythm control it. So to discuss this better, I have a flow chart. So yeah, so if it's a very new patient, someone presenting to you like very fresh, almost less than 24 hours, new AF, you can have two approaches, either to rate control it or to rhythm control it then and there. Most of these patients would benefit from a rate control approach, and some patients in some selective category, you can decide that a rhythm control approach would be good for these patients. So such patients, we need to follow the rhythm control strategy, and I'll speak about it later. So if you decide to do the rate control, first line management, then the best agents would be beta blockers, non-dihydropyridine calcium channel blockers, and then digoxin. So you give one of these agents and then check them again after 2 to 3 hours, and then see whether they have come back into sinus rhythm, or they have their rate is controlled. If they have come back into sinus rhythm, or their rate is controlled, you can technically discharge them from the ED, but they will need anticoagulation, and further follow-up, you will need to arrange medicine or a cardio follow-up after that. If the patient is still symptomatic, if the patient is still having tachycardia, then you might have to admit them and then review them with your senior help, and then decide on further courses of action, adding or increasing the dose of these beta blockers and observing the patient. Yeah, if it's more than 130, then you might have to admit the patient and then decide on the management. So what are the drugs that you use? You can use metoprolol, which is available as intravenous. You can give a slow 5 milligrams metoprolol first, and then 5 milligrams more after some time if needed. And the max dose of 10 to 15 milligrams of metoprolol can be used if an IV drug is needed to control. And then the other beta blocker option that you have is bisoprolol. You can use 1.25 milligrams. From there, you can go up to 10 milligrams. Yeah, and then you always start bisoprolol at a very low dose, and then see the response, and then go up. You can also use drugs like diltiazem, and then always there is the option of using digoxin. Okay, so that is about these drugs, and then that's how you manage an an atrial fibrillation with a rate control strategy. If you decide to, okay, sorry. So this is again the rate control. How do you do it? So basically, if there are no comorbidities or anything, you use beta blocker or non-dihydropyridine calcium channel blockers. If there is patients with heart failure with reduced ejection fraction, beta blocker is the better first line, and then second line always it's digoxin. Then if there is a COPD or asthma, it's difficult to give a beta blocker for such patients. In such patients, you can use something like diltiazem. So you can give the calcium channel blockers, and that would be how you rate control these patients. And then next is rhythm control. So I said in a selected group of patients, you can technically do rhythm control. What is the selected group of patients? So someone who is presenting under 24 hours, some literature says under 48 hours, but for all practical purposes, it's better to stick with less than 24 hours. Mainly the worry is clots that are being formed in an atrial fibrillation rhythm or something like that. And yeah, so someone who is presenting under 24 hours with no signs of heart failure, no signs of ischemic heart disease or myocardial infarction, and then with ECG that not showing any morphological abnormalities or any other abnormal conduction apart from the AFib, and then no previous thromboembolic events. In such patients, you can consider doing an early cardioversion. You can control their rhythm by using an early cardioversion strategy. So you can use pharmacological agents to cardiovert them. But even if you use a pharmacological agent like flecainide to cardiovert and control their rhythm, remember the problem in all these patients is you need to anticoagulate them well with a low molecular weight heparin or a directly acting oral anticoagulant. So that is the most important thing. And then you control their rhythm using pharmacological agents, and you can either discharge them, then, or if unsuccessful, you need to discuss with your seniors and then consider either you should consider a DC cardioversion or further infusion of pharmacological agents, and then controlling it. Patient will need better monitoring and things like that. In some patients, if you're not going down the pharmacological way of controlling or reverting the rhythm, what you can do is the other option is elective cardioversion. So for that, you need to better to involve your seniors and then planning the cardioversion and cardioverting the patient. So in all these things, just remember you need to anticoagulate the patient before changing the rhythm, before cardioverting or before doing a rhythm control. You need to anticoagulate the patient. That's the most important thing that I want you guys to take away from this slide. Okay, so next is again I would like to stress the anticoagulation part of it. So there are many tools like say CHA2 DS2 WASC score, and that's for the risk of developing a stroke. And then there are bleeding risk calculators also, something called Orbit and Hasplat. If you just go to MD Calc, you can calculate these scores, and then you can take a decision whether to anticoagulate or not. It's important that you do this before you anticoagulate any of your patients. What happens if the patient is presenting in an unstable state? So the previous two slides were talking about a patient who came stable to you, but with some symptoms. And you saw when you took the ECG, you saw the atrial fibrillation. Now the patient is unstable. If the patient is unstable, what you do? You just need to follow your ABCD approach and then look at what are the adverse features. If the patient is unstable, it's advisable to do a DC cardioversion. So DC cardioversion is the choice of management if the patient is unstable. A synchronized DC cardioversion. Remember, it should be a synchronized DC cardioversion. All you need to do is press the sync button on your defibrillator, and it will sync it and then deliver the shock. Okay, pharmacological agent would be amiodarone. Yeah, and then if it's getting complicated, seek expert help. Next is AV nodal reentrant tachycardia. So here what happens is there is some tissue. So this yellow bit here is the AV node, and just around it, some tissue can cause some re-entry circuits basically, and one will develop a fast and a slow conducting channel, and then that can cause re-entry circuits through the AV node, and that will cause AV nodal reentrant tachycardia. So how would patients present to you? Patients would present to you with a syncope or pre-syncope, chest pain, dyspnea, anxiety, and then some patients they'll complain of an incident of like passing quite a lot of urine, basically because of the release of atrial natriuretic peptide. So you'll just hear you might hear the history of a polyuria also. It can just happen spontaneously or with some provocation like caffeine, alcohol, salbutamol, beta agonists, sympathomimetics, amphetamines, and things like that. There will be tachycardia, and the rate would be 140 between 140 to 280, and sometimes it can just resolve on its own, or it can just continue on till medical treatment is sought. Okay, so sorry. Yep. Okay, so types. So there are slow, fast, fast, slow, and slow, slow types. And in all these, so what happens in a slow fast is basically there will be a P wave that's obscured in the QRS complex, or a pseudo R or S at the end of QRS complex. I'll show you the ECGs and you'll be able to see an example of it. One sec. Yeah. Okay, so if you take a look here, yeah, so this is an example of AV and RT. Okay, so yeah, here you can see narrow QRS complex at a high heart rate that's going on. You can't definitely see P waves here, but in some leads, if you see, there's just in V2 and V1, just after the QRS complex, you can see a pseudo R wave. So here's a magnified image of that. So just here, you can see something called as a pseudo R wave. So this happens when it comes right after the QRS complex. It's mostly a slow, fast type of AV NRT. So yeah, so if you see a patient with high heart rate, where you can't even figure out where the P wave is, and the rhythm is narrow, regular, complex, regular rhythm. So it would most likely be a supraventricular tachycardia, most likely an AV NRT. Okay. So how would you manage this? So first step of management is some vagal maneuvers. So that's you give some carotid massage, and that can help in abolishing this rhythm. Drug management would be to block the AV node. So how you block the AV node? The preferred drug of choice is adenosine. So you give 6 milligrams first, 12 milligrams then, and then 18 milligrams, one after the other. If one is not working, then you escalate the dose and go forward. Tricky thing with adenosine is you need to give a fast IV flush. It can easily get disintegrated very fast in the peripheral circulation. So you need to ideally cite a cubital fossa cannula, a good wide bow one, load up adenosine in your syringe, take up a flush also along with you, connect it to the cannula, fast IV push adenosine, and immediately followed by a 10 to 20 ml of saline flush also. So that's how you treat a stable patient pharmacologically, a stable AV and RT case. So second line agents would again be calcium channel blockers and beta blockers. If this is not working, if the patient has become unstable, then again, important thing, what you need to do is electrical cardioversion, a synchronized one. Initial energy would be from 50 to 100. And if it's becoming very unstable and the patient is very sick, then you might have to start off with ACLS protocols. Okay, so that is AV-NRT. So just to summarize, in AV-NRTs, the node is involved. There is some reentrant circuits formed around the AV node. So an impulse will come out from one end of the AV node and then go into the AV node from another end, and then that from the AV node it will also get conducted down to the ventricles, just following the normal pathway. So you will just see a narrow regular QRS complex. You may or may not see a P wave because the rate is high. And then the P wave would just be in between the QRS complex, inside the QRS complex, or right outside the QRS complex. Look for pseudo R waves. If you find pseudo R waves, yes, that's mostly an AVNRT. Next is AVRT, so atrioventricular reentrant tachycardia. So this is commonly seen in patients with Wolff-Parkinson-White syndrome and things like that. So basically, these patients will have an abnormal conduction pathway which has remained in their heart from birth, and it never went off. So that abnormal conduction pathway will sit there, and then these normal impulses generated from SA node, and then it will come through AV node, come down, and then form reentry circuits through these abnormal conduction pathways. And most common sites where these abnormal conduction pathway are found on the left atrioventricular junction, and then in the septum, and yeah, those are the most two common sites. But left atrioventricular junction abnormal conduction pathway is the most common. Two types of AV reentrant tachycardia. So atrioventricular reentrant tachycardia. So impulse coming from atria, ventricle, and then it's re-entering into the atria and then forming a loop and then continuing. So two types. It could be either orthodromic or antidromic. So in orthodromic, basically the event happens in the atria, and from the SA node it comes down all the way, and then through the AV node it enters the ventricles, and then through the abnormal conduction pathway it just travels back into the atria again and then continuously stimulate the AV node. So that forms a loop there, and it is called orthodromic. It's called orthodromic mainly because the forward conduction is through the normal conduction pathway. And it's called antidromic when the forward conduction is through the abnormal conduction pathway. So from this itself, what you can make out is when the forward conduction is through the normal conduction pathway, the QRS complexes would look narrow because the conduction is happening very fast and it would be narrow in shape. But if the conduction, if the impulses are entering the ventricle through an abnormal conduction pathway, that is through in the antidromic one, so it is entering through the abnormal conduction pathway. Obviously, once it enters the ventricle, for it to spread, for the impulse to spread throughout the ventricles, it will be very slow because it's not the specialized conduction tissue that is conducting the impulse throughout the ventricle. It is through myocyte the impulse is traveling, so it will be slow. So once it's slow, the QRS complex will be large. So you will see broad complex tachycardias in antidromic, and you will see normal complex tachycardia, normal small QRS complex tachycardias in orthodromic. This is an example for an AVRT. Okay, so Yeah, so this is an example for an AVRT. So here also it's no normal, and this is orthodromic narrow complex tachycardia. So if you look closely, you can see a small P wave just before the T wave in V1. I tried to look very closely, but yeah, it's very difficult to figure out. If you don't figure it out, it's all right. Yeah. Okay. So orthodromic AVRT, the ECG features, just as I told you earlier, it's the same thing that I've written here. So orthodromic AVRT or just AVNRT. So that is the confusion. So I told about AVNRT, which would look like this, and then AVRT, which would look orthodromic AVRT, which would look like this. So how would you differentiate these two and then treat? The thing is that you technically don't have to differentiate these two. It's very difficult, and the treatment is more or less the same. So fortunately, we are saved there. There are technical details in differentiating these both, but in the interest of time, we'll just don't go into much deep than this. Okay, then as I told, antidromic AVRT, this is seen here. So this is the antidromic one, where the conduction is happening through the forward conduction is happening through the abnormal conduction pathway. And yeah, so in an antidromic AVRT, it's seen in patients with WPW syndromes. Yeah, and the problem is you can easily get confused with VT. Because the QRS complex is going to be broad. So most of the time we will end up treating it as VT. So we should, if there's any doubt, it's always best to presume the diagnosis of VT and then treat accordingly. Ideally, the management should be by procainamide. That's a class 1 antiarrhythmic. And then there you can use ibutilide and amiodarone as second line. But in most of the cases, what happens is in an emergency situation, this will make a presumed diagnosis of VT and then continue to treat it. This is how it would look like. Broad complex tachycardias. Yeah, regular broad complex tachycardia just look like VT. Okay. So yeah, it's nice to discuss about WPW and AF and WPW and things like that, and then differentiating VT and SVT with aberrancy. But it will be very deep if we continue to go down. You can have a look on these topics, and then it will help you if you want to understand more. So next is junctional rhythm. So here, this is also called, this is an example of junctional ectopic. So there's no P or anything that you can see here. Here it's a normal beat just followed by immediately by another one. It's originating in the atrioventricular junction, and then it's conducting through the normal conduction tissue, normal QRS complex, and then there is a compensatory pause, and then the normal QRS complex is followed with the P wave in front of those. So one-off ones just like that, without any atrial, without any P or any electrical event like that, then that would be a junctional ectopic. Many names: junctional extrasystoles, junctional premature beats, junctional premature depolarization. It all means the same. A junctional escape rhythm, when the same thing transfers into a rhythm, that is a junctional escape rhythm. So basically, again, when the SA node fails, a region in the heart in the AV junction takes up the command, and then it continues the beat. So that's when you see a junctional escape rhythm. So you see absent P or a P that's lost in QRS. You don't see any P, and then a normal narrow QRS complex, regular ones, just continuing on. That would be a junctional rhythm. Rate would be a bit less compared to a normal SA node junctional rhythm. Causes are sinus arrest, again, dyslipidemia, atrioventricular blocks, drugs that is causing the block, beta blockers and calcium channel blockers or digoxin poisoning would be the causes. So yeah, you need to look at the cause, find out what is causing this junctional rhythm, rule out all these causes, and yeah, and that's how you manage. And then you manage the cause basically. If the heart rate is going quite down, then you might have to consider atropine, and just to bring the heart rate up. Yeah, that's one thing that you need to remember. Symptomatic bradycardia, you need to treat it with atropine. These patients, if the heart rate is very low, causing symptoms and trouble to them, they will need pacing as a definitive management. Junctional tachycardia, again, this is an accelerated junctional rhythm. So as again, a same atrioventricular junctional pacemaker is doing it. That is the boss here. So that is commanding the electrical rhythm, and the heart rate is, there's a ventricular rate 60 to 100. You might see these abnormal retrograde P waves because the impulse is conducting back. It's traveling back from the junction into the atria. So you'll see inverted retrograde P waves and things like that. So this is an example for junctional tachycardia. Okay, so next, so we completed junctional rhythms, and then next is ventricular rhythms. So complete heart block, and then ventricular escape, accelerated idioventricular rhythm, VT and VFib. We'll focus more on VT and VFib because that's the most common thing that you need. So one important thing here is ventricular extrasystole. So, or a premature ventricular beat or ventricular ectopic or something like that. These are called in different names. So this is basically a ventricular beat arising from the ventricle, and it's not following the normal conduction pathway. Hence, you can see a broad QRS complex and inverted T wave, and just one off, just like that. So that would be a ventricular ectopic beat. So will be bigger than, QRS complex will be bigger than 120 milliseconds. Abnormal morphology, that's premature, happening before the supposed normal P wave and the QRS complex are supposed to happen. It's a premature beat, and then usually it will follow a compensatory pause. So you can see this is the normal RR interval. There is a premature ventricular beat here, and then there is a 2 times RR interval, a compensatory pause here, and then the T wave will always be right opposite in direction towards to the QRS complex. So when you see something like this as 1 of 1, that would be a ventricular extrasystole. What are the causes again? Anxiety, sympathomimetics, beta agonists, caffeine, dyslipidemia, digoxin toxicity, MI, things like that. This can be quite common in patients, and it can just be benign. Just take a look at if you see something like this in the monitor of your patient, then take a ECG, take a rhythm strip, see how frequent these ventricular ectopics are. If they are very frequent, you might have to keep a close eye on this patient because they can easily degenerate into VFib and VTAC and things like that. If not, if it's very infrequent, then it's something that you won't have to worry about. Also take a look at the QT interval of these patients. If there is a prolonged QT interval, then there could be something called an R on T phenomena, and that's basically the premature ventricular beat that is happening here. So this premature ventricular beat will happen exactly when the T wave of the previous normal beat is happening. So R on T. So that will happen when the QT interval is long. So when the QT interval is prolonged, R on T phenomena can happen, and then it can go into VFib or VTAC. Okay, so yep, so we finished that. And then ventricular escape. Okay. Yeah. So ventricular escape rhythm is when SA node failed, nothing from junctional rhythm didn't happen, that also failed, and then the ventricle is just beating on its own. So obviously the ventricle escape rhythm or the ventricle pacemaker cells would be at a very, very low rate, and that would happen 20 to 40 beats per minute. You will see broad QRS complexes. And you will see broad QRS complexes. So it would look something like this: broad QRS complexes, bigger than the normal ones. Broad QRS complexes, very slow, absent P wave. So yeah, that will be how a ventricular escape rhythm would look like. These are commonly seen in patients with sinus arrest, bradycardia, and 30 like hyperkalemia, post-MI, and things like that. Okay. Next is accelerated idioventricular rhythm, when the rate of ventricular ectopic pacemaker exceeds that of a sinus node. So there's a ventricular ectopic pacemaker that's taking up the role, and it just keeps on going forward. Okay, so that's when an accelerated idioventricular rhythm would happen. Again, the causes are: one is the reperfusion phase of MI, drug toxicity like digoxin, electrolyte abnormalities, and when a patient is returning back to ROSC following an MI and a cardiac arrest. So this is a ventricular ectopic one, so that is continuing. So you can see 1, 2 ventricular ectopic beats coming one after the other. So that's a ventricular ectopic rhythm. That's how it would look like. So it's just 2 coming here in complexes and then normal ones coming. So and it's sustained, you can say accelerated idioventricular rhythm. So treatment would basically like focus on the underlying condition. Most of these things patients would be right after an MI or something like that. So yeah, that would be the cause of that. Okay, so
Alex, sorry to interrupt. Just a reminder that you're a bit short on time.
Yeah. Sorry. What's the time now?
It's about 9:40 here. So
yeah, I'm winding up soon. This is just last few slides. Okay, so next is VT. Again, the most important part of this discussion. So broad complex tachycardia, very regular, large QRS complex, larger than 160 milliseconds, and then a high rate. This is how a monomorphic VT would look like. So broad ones, just that's ventricular tachycardia. It's very striking. This should just stay in your head. The minute you see this rhythm on the screen, yeah, that is it. You know it's a VT, and then you need to immediately manage it. Then there's something called polymorphic VT and Tosadas de Pointe, and it's basically VT that's changing in its morphology. So that's something how it would look like. Yeah, again, broad complex QRS complexes that is twisting around an isoelectric line. That's how Tosadas de Pointes would look like. In polymorphic VT, QRS complexes would just vary in its amplitude, axis, and duration. Okay, so yeah, that's an example for VT. So you can see that there are broad complex tachycardias, just regular broad complex tachycardia, and that is VT for you. There is a discussion on differentiating VT and SVT that I put in, but I think if you go into that, it's going to be a bit more complex. So at the moment, we'll just skip it. So there's a 4-step Brugada algorithm that you need to follow through when you differentiate a VT from an SVT. So straightforward SVT, you can easily differentiate it because most of them will be narrow complex tachycardia. But the trouble arises when the SVT happens with a bundle branch block or there is an antidromic ABRT, as we discussed earlier. So in such cases, again, the QRS complexes would be broad, and you might have to differentiate these two. But in all such cases, to be fair, when there is doubt, always treat it as VT. That would be the end line of it. Okay, and how would you manage? So if the patient is without pulse, then basically you need to follow the ACLS protocol. So if the people who attended Clive's class the last week, they know how to go forward with the ACLS protocol, ABCD approach, and then IV access. So that's how you go forward with it. The drugs used would be amiodarone, and basically just follow the ACLS protocol for a pulseless patient, and nothing fancy, adrenaline and amiodarone. And then you need to like think what is the cause for this arrest. It's an arrest scenario, and just manage it as an arrest. If the patient is just clinically compromised, that's you still have a pulse, but there are signs of clinical compromise: chest pain, ischemia, heart failure, patient is hemodynamically unstable. Then the important thing is to exclude what would be the causative factor for this VT. So dyselectrolemia, check your magnesium and potassium. Catheter in RV, that is basically when you do a central line or something like that. So exclude any of those wire. That's the same thing. And then just in your bone center, mostly check potassium and magnesium, but you won't have time for that to come back. But if it's a clinically compromised VT, you see it in the ECG, you need to give amiodarone infusion, 5 milligrams per kilogram. That's the dosage. That's the pharmacological management of it. There is another school of thought where it's still debated whether pharmacological management or giving a synchronized cardioversion, a DC shock would be the best thing. I think the choice would be based on clinical scenario and from clinical experience and expertise. I personally think giving the DC shock would be better, but I think Chaitanya Sir can help us with the dilemma around here. Synchronized cardioversion, increasing from 50 joules to 100 joules slowly, one after the other. That's mainly about the management of VT. Then we have ventricular flutter. So that's how a ventricular flutter would look like. So when a patient is in VT, patient can easily degenerate into ventricular flutter and then into a VFib. So ventricular flutter is a transient state, mostly that's happening between a VT and a VFib, and then it would be something like this. Very sinusoidal pattern would be there. Narrow again. It's broad QRS complexes, very sinusoidal, very fast. And here your management, there would be the ventricles are contracting very fast. The cardiac output will be very less, and then patient will be in shock, hemodynamic collapse. You need to follow the ALS protocols and then CPR and shock. Then this is VFib, ventricular fibrillation, again another shockable rhythm. So two shockable rhythms, VT and VFib in absolute emergency. So VFib, again very narrow, very chaotic complexes, and you can't see any P waves, no QRS complex, nothing, just some coarse, narrow complexes happening at a very high rate. Ventricle is not even properly contracting. It's a fatal situation. You need to act immediately and then shock it. So this is a table that you can use to like work through and then find out what rhythm the patient is in. I'll share these slides and all these resources with you so that you can go through it again. It's a very big topic that I covered. Tried to cram a lot of stuff into it as much as possible. I've thrown a lot of information onto your head, but you will have to go through it again mostly. Okay. I think I just finished it. Thank you. Chaitanya sir, can you take over?
Absolutely. I think Alex has done a fantastic job. He hasn't left me with anything to do, in fact. I think if you all understand how difficult approaching this topic is to explain to people, and let's made it extremely simple. I think while the slides look very detailed, he's really broken it down. I think using this resource and all the live examples that he's given is going to be very useful for anybody here. I'm not going to take too long, maybe just 5 minutes max. I'll just share my screen. Just a repetition of what Alex said, just to reiterate what he said. I think I had stopped at axis. Yeah, are you able to see my screen?
Yes, sir.
So just to reiterate, Alex stressed that when you eyeball an ECG, though the SAM technique is really nice, and I think that's something that I found on Life in the Fast Lane as well, which is an extremely valuable resource. I think the simplest thing which he mentioned was look at one in AVF. Whenever you're looking at access, the two most reliable leads are one in AVF. Generally, of course, both having to be positive. And you can always add lead three as a supplement to it. That becomes your lead technique. So if you look at the ECG that I've put up, lead one, the QRS is predominantly positive, AVF is negative. And if you add lead three, that's also negative. So this becomes left axis deviation. So always remember one AVF are the leads to go to if you want to establish access. And just to reiterate that a positive QRS complex is where the R is more than the S. Don't worry whether there is both R and S together. You're looking at the height of the R wave more than the S wave. That's its R. If the R and S are equal, we call it equiphasic, which you will sometimes come across, especially in V3. And if S is more than R, we call it negative. So you don't need to have only R or only S, you can have both. This is a repetition of the axis diagram that Alex put up with. A normal QRS is always 0 to 90, but there is some physiology between 0 to minus 30, and this is common in, especially in pregnant women, you can have a physiological left axis deviation. But whenever the AVL becomes negative minus 30 to 90, it's always LAD. If AVF is on the negative aspect, one is on the negative aspect, AVF is positive, then we call it RAD. And if both are negative, which is a very rare phenomenon, we call it extreme RA. I just like to put up this. This is, I think, the last two tables that Alex put up. This is a flowchart version of exactly same. And this is something that I've taken from an old British journal. And I find this extremely valuable. I'm not going to go into the detail because it's a very busy slide, but this is an algorithm that I've always used from the time of my internship, and I have found it to be extremely easy to apply when you approach a patient with a high heart rate. So any approach to tachycardia, if you can follow this slide or this flow chart, just take a screenshot, keep it with you wherever you go. It's extremely easy to apply. And the accuracy rate of this is almost 90%. And this, in fact, this flowchart has been, verified in the UK. And I've been using it for almost 8-9 years now, and I've never gone wrong if you go in this particular one. And it basically tells you that when you look at a high heart rate, what order to go into and how to look at it. So just to reiterate how important it is, I just put up a couple of examples and then I'll stop. So we have a young lady who presents with 3 episodes of sudden onset rapid palpitations lasting for 10 minutes. She feels very lightheaded at that time. And she also noticed that after every episode terminates, she's had 3 of them, she wants to pass a large volume of urine. And while this history is not common, it's very specific. Post palpitation polyuria, and it's classical of a type of arrhythmia, which I'll come to. She's come to you, she's having palpitations, her heart rate is 160. It's regular. JVP shows prominent neck veins with a normal blood pressure. And this is her ECG. So if you eyeball the ECG at first, as I always said, look at the calibration, and Alex mentioned that the calibration is normal. It's definitely tachycardia. The heart rate's definitely more than 150 because it's 300 divided by 2 big boxes. The axis, if you look at it, one is negative and AVF is positive, so it's actually leaning towards the right axis. And if you look at the QRS complexes, they are narrow. So all the QRS complexes are narrow and there is no visible P wave. So if you follow the algorithm, a heart rate of more than 100, look at the QRS if it's narrow or broad. Any narrow QRS, as Alex mentioned, is supraventricular. So anything from the atria will have a narrow complex. Anything from the ventricle will be wide complex. And that is something you should keep in mind. There are exceptions, of course. So here we've got a narrow complex tachycardia. It's regular, definitely. Is there a P wave? No. So when you have a regular narrow complex tachycardia with no P wave, you're either dealing with a flutter or an AV and RT. And in this case, if you go back to the ECG, Alex had already mentioned, you have a small R wave that you can see here if you zoom in closely. and that's called the pseudo R dash pattern. It's actually the P wave attached to the QRS as the S wave terminates. It's called the pseudo R dash pattern, a very similar ECG here put up. And this is classical AVNRT PSVT. So this will require adenosine, which will terminate it immediately. Very common presentation in patients. On the other hand, you have a sports person who's collapsed on the playing field, rushed to the emergency department, a regular 200 beats per minute pulse with only a 60 systolic JVP. And if you look at it, this is the ECG that you see. So I've shown you two contrasting ECGs, both of patients. One is a conscious patient who's had 3 episodes of palpitations. This is somebody who's collapsed. And if you look at it and you eyeball it straight away, you can see that the calibration is okay. It's on the right side of the screen. But if you look at it, your axis is extreme right axis. And the one is negative, AVF is negative, which means it's extreme right axis. Alex mentioned something about Brugada's algorithm, which is the most accepted algorithm. There's something called Brugada's rule, which is a it's a cheat. It's a shortcut. If you're dealing with a wide complex tachycardia, your biggest differential diagnosis is VTAC versus SVT with aberrancy. If you look at AVR and AVR is positive, it is 8 out of 10 times it is VT. So AVR positivity in the background of a wide complex tachycardia is called Brugada's sign, which is part of Brugada's algorithm. This tells you that it is definitely VT. And if you apply my tried and trusted algorithm, heart rate of the QRS heart rate is more than 100. It's a broad complex QRS. You can see that the QRS complexes are more than 3 boxes. It's regular. It has to be either VT or SVT. And that's when you apply the Brugada's algorithm. As Alex had shown you, but I didn't think he stressed on it because of time, is you see Josephson's sign and Brugada's notch. You can read up about those. But this is somebody who needs a shock because cyst is systolic. And I completely agree with Alex. I think DC shock is the way to go when you have a VT in cardiogenic. This is again Brugada's algorithm and the inferior Q wave criteria, the 2 criteria that are currently used to differentiate VT from SVT. And if you look at it, remember AVR positivity becomes a soft. And of course, this is the last slide of today's class. If you look at this, I just want to stress on bradycardia because that's something that we also see. And if you look at this ECG, Alex's first slide today said, if in trouble, look at lead 2. I completely agree at that. If you look at lead 2, you can see P waves and QRS complexes occurring in complete dyssynchrony. The P waves are occurring at this interval, which I'm showing with my pointer, while the QRS is occurring separately. This is classical AV dyssynchrony in the scenario of bradycardia. This is a complete heart block. And of course, I had to mention CHB, complete heart block, to end today's class. So once again, I think Alex did a fantastic job. You're all going to really benefit when you go back, listen to the video and see all the slides that he's painstakingly put through. And if you just follow the instructions that he gave you when you look at an ECG, access calibration, and then look at how he dissected each rhythm, you will never go wrong. Reading ECG is an art. It's something that you will master only with time, if at all. But I think the more you see and the more you read and the more you apply what you've learned today, I think you guys will master it soon. Thank you, Alex. Fantastic job.
Thank you, sir. Thank you for the kind words. Yeah. Thanks everyone for listening patiently through this long session. I know I overshot the time limit by quite a lot, and I apologize for that. Yeah, thank you. Thank you all.
Jatin, you're on mute.
Sorry. Thank you, Alex. Thank you, sir, for the very detailed class on ECG, basics in ECG. So we'll take any questions if anyone has any doubts.
You can either unmute yourself and then ask us, or just put something in the chat box. We'll try and answer that. Okay, looks like we haven't got any questions yet.
Okay then. Yeah. So thank you everyone for attending today's lecture. So details regarding further lectures shall be posted soon on all social media and WhatsApp also. So please be on the lookout for further lectures. So again, thank you, Dr. Alex. Thank you, Chaitanya sir. And good night, everyone. Thank you.
Good night. Thank you, sir. Bye.
Thanks, Alex. Thanks, Chetan, for hosting it. Thank you so much.
Thank you.